Okay, let's take a deep dive into a condition that can be incredibly challenging for both patients and clinicians. Avascular necrosis.
Hmm.
It's also known as aseptic osteonecrosis, and it's something that can be truly debilitating, progressively disabling over time.
That's right.
While it can develop in several bony districts throughout the body, we most commonly see it and, well, hear about it affecting the femoral head.
Exactly. And what's fundamentally happening here, what makes it so tricky, is really a problem with the blood supply. It stems from reduced vascularization of a terminal vascular bed.
Okay.
Think of areas like the femoral head, which is a very specific and, well, somewhat precarious blood supply pattern.
Right.
But this same issue can pop up in other similar distributions. The femoral condyles, the humeral head, bones in the foot like the talus, the calcaneus, the navicularis, and other bony structures that really rely on these endpoint vessels.
And that compromised blood flow leads directly to a state of hypoxia, basically, a lack of oxygen at the cellular level within the bone tissue.
Precisely. It's these hypoxic conditions that really mediate the entire disease process,
Yep.
ultimately leading to osteonecrosis, the death of bone cells.
It's a spectrum, isn't it? We know this condition exists on a spectrum, from very subtle symptoms initially to something requiring major surgical intervention down the line, like total hip arthroplasty when the disease gets advanced.
Absolutely. And that range in severity and treatment options is exactly why understanding it thoroughly is so crucial.
Right.
Our specific mission in this deep dive is to take a really comprehensive look at the source material you've provided on avascular necrosis treatment, with a particular focus, as you said, on the evidence and application of hyperbaric oxygen therapy.
Okay.
We're going to explore what these sources tell us about its role in managing this challenging condition, sort of peeling back the layers of the proposed mechanisms and the reported clinical outcomes.
So how are we going to unpack all of this? Here's our roadmap, our plan for this deep dive. We're going to kick things off by formally defining avascular necrosis and critically understanding how it's staged.
Very important.
That staging process is absolutely foundational because, well, it guides every treatment decision that follows. Then we'll survey the landscape of other treatments available besides hyperbaric oxygen therapy, just to give us the context of current approaches. Everything from medications to non-operative procedures and other surgeries.
Right, the baseline.
Exactly. After establishing that baseline, we'll dedicate significant time to hyperbaric oxygen itself. First, delving into the proposed mechanisms, how exactly is this therapy thought to work at a cellular and tissue level to potentially halt or even reverse this process?
Okay.
Then we'll examine the clinical evidence presented in the sources, looking at the published studies and reports to see what they actually say about its effectiveness in real-world scenarios. We'll broaden our scope a bit to look at its application and reported outcomes in anatomical sites beyond just the femoral head because, as you said, it's not limited to the hip. And finally, we'll translate all of this into practical terms by covering the specific recommendations and detailed treatment schemes outlined in the source material for utilizing hyperbaric oxygen therapy in clinical practice.
Yeah, we're aiming for an in-depth exploration here, really rigorously grounded in the source material you've provided. Our goal is to extract the critical knowledge and key insights that you, as a specialist clinician listening, can directly apply in your own practice. All while, keeping the conversation engaging and highlighting those crucial details that really make a difference.
All right, let's jump right into Chapter 1 and lay the groundwork. What exactly are we talking about when we say avascular necrosis?
Okay, so the sources define it formally as avascular necrosis, or AVN. It's also referred to as aseptic osteonecrosis, or AO. It's a condition that, importantly, can develop in several osseous districts throughout the body.
Right.
But as you highlighted earlier, it's most commonly described and probably most notoriously impactful as avascular necrosis of the femoral head, or AVNFH. The sources specifically call out AVNFH as a debilitating and progressively disabling condition, which really underscores its clinical significance.
And the root cause, the etiology and pathogenesis. The source says it's partially understood and wide-ranging, so it's not always one simple thing.
Not always, no. It can be complex. But the chief cause, the core problem, is that reduced vascularization we touched on, that insufficient blood supply to a terminal vascular bed.
Okay.
And it's not just the femoral head. The sources emphasize this can happen in other areas with similar delicate vascular distributions. They list the femoral condyles, the humeral head, the talus, the calcaneus, the navicularis, and other bony structures too.
And the direct consequence of that reduced blood flow is the creation of those hypoxic conditions, this lack of oxygen at the tissue level.
Right, that mediates the entire disease process. Now, it's interesting that right here at the outset, the sources introduce the idea that these hypoxic conditions can potentially improve with a course of hyperbaric oxygen, hinting at the potential role of HbO2 in maybe directly addressing that underlying oxygen deficit that drives the necrosis.
That's a good hook for later. Shifting focus slightly, how does this condition typically present clinically? And what we know about its prevalence, who gets it?
Well, the sources point out that the symptom onset is usually quite subtle. Often there's a tendency for the progressive functional limitation that's occurring to be underestimated.
By the patient, you mean? Or
Both, potentially. By the patient and perhaps initially even by clinicians if the early signs aren't specific.
And how does the pain pattern typically evolve? Is there a classic progression?
There is. The typical pain progression is a key characteristic. Initially, patients usually experience pain primarily at weight-bearing, standing, walking, putting load through the joint.
Right.
As the condition advances, this pain often worsens and becomes present even at night, sometimes waking patients from sleep.
Oh, okay. That nocturnal pain is often a red flag, isn't it?
It is. And frequently, it's the symptom that finally prompts a patient to seek their first formal clinical checkup.
Mm-hmm.
But unfortunately, as the source notes, by this point, the disease might already be relatively late in its course.
And who is typically affected? What age group?
The sources tell us it usually affects the age range of the most active population, often between 40 and 50 years old.
Mm-hmm.
And this has significant ramifications, not just for the individual patient, but more broadly.
Right. It's not just the personal impact. There are wider effects.
Exactly. It has significant repercussions on the patient's quality of life. It's progressively disabling, and if left untreated, it can lead to femoral head collapse, potentially requiring surgery, usually a total hip arthroplasty.
Yeah.
But the sources also point to its effect on the general economy, due to the reduction in ability and work performance of affected individuals who are often in their prime working years.
Are there numbers on this? Prevalence?
There are. An estimated 20,000 to 30,000 cases of osteonecrosis are reported in the United States each year. And there's been a notable trend of increasing rates of total hip arthroplasty, specifically due to AVN. It rose from about 54 per 100,000 hospital admissions in 2001 up to over 60 per 100,000 hospital admissions in 2010. Those are pretty impactful statistics.
They really highlight the burden. Now, to get a handle on this condition and plan treatment effectively, staging is absolutely essential, especially for the femoral head. The sources emphasize one of the most widely used systems, the FICAT classification.
Right, FICAT. It was developed and historically based on the appearance of the femoral head on a plain radiograph, an X-ray.
Before MRI was common, presumably.
Exactly. This was the primary imaging modality available before the widespread adoption of magnetic resonance imaging. However, the sources are, well, pretty unequivocal now. Magnetic resonance imaging, or MRI, is the ultimate gold standard for the specific diagnosis and assessment of vascular necrosis today.
Because it sees things earlier.
Much earlier. MRI can detect changes much, much earlier than plain X-rays can pick them up.
Okay, let's break down those 4 FICAT stages for avascular necrosis of the femoral head as they're detailed in the source. Stage 1.
Stage 1. This is the earliest stage. Pain is present, so the patient is symptomatic, but critically, there are no radiographic anomalies visible on a plain X-ray.
Okay, so visualize this. You'd look at a plain X-ray of the hip and it would appear completely normal even though the patient is telling you they have pain.
Correct. The disease process is happening at a microscopic or very subtle level, not yet detectable by that plain film.
Then stage 2.
At this point, changes do become visible on a plain X-ray. Stage 2 is characterized by signs like increased density, sort of whiter patches within the bone of the femoral head, maybe cystic changes, or a mottled or porous appearance.
So you can picture maybe patchy or mottled areas starting to show up within the bone head on the radiograph.
Exactly, indicating areas of necrosis and maybe some attempts at repair, but crucially, the overall structural shape of the femoral head is still preserved. It's still round.
Then we get to stage 3. What happens here?
This is where more significant structural changes occur. Stage 3 is characterized by 2 key findings on plain radiograph. First, flattening of the femoral head, it starts to lose that smooth spherical shape. And second, the presence of the crescent sign.
The crescent sign. Can you describe that?
Yeah, you can visualize the femoral head beginning to deform, losing its roundness. The crescent sign represents a subchondral fracture line, basically a crack just beneath the joint surface cartilage. It indicates impending collapse of the articular cartilage and the underlying bone. It looks like a thin, dark line following the curve of the head.
Okay, a bad sign. And finally, stage 4.
Stage 4. This represents advanced end-stage disease. Stage 4 is characterized by full collapse of the femoral head. The structural integrity has failed significantly, and this is accompanied by a decrease in the joint space between the femoral head and the acetabulum, the socket.
So picture the femoral head severely deformed, flattened, and the space where the joint articulates becoming noticeably narrowed due to cartilage loss and bone collapse.
Precisely. And understanding these stages is absolutely paramount because they directly influence treatment goals. Many proposed treatment options, particularly when the disease is identified in its earlier stages, aim squarely at joint preservation.
Trying to save the hip?
Exactly. The goal is to save the patient's native femoral head and avoid or at least delay the need for a prosthetic replacement for as long as possible.
But, as the source makes clear, there's a point of no return for joint preservation based on this staging system.
Yes. When the radiological signs progress to advanced bone collapse within the articular capsule, specifically FICAT stage 4, the single mandatory surgery approach, according to the sources, is a femoral head replacement with total hip arthroplasty, or THA.
So, at stage 4, preservation is generally off the table.
Generally, yes. It's no longer considered a viable or recommended option.
And this is where hyperbaric oxygen therapy potentially fits in, based on the opportunities identified in the sources linked specifically to these FICAT stages.
That's right. The sources lay out a couple of key opportunities.
The first opportunity presented is in the early stages, FICAT stage 1 and FICAT stage 2. What's the potential outcome there, according to the source?
In these early stages, the sources suggest a significant potential outcome with hyperbaric oxygen therapy. Complete recovery might actually be achievable, not just in the imaging findings, but also alongside functional improvement from the injury and effective pain control.
Complete recovery, that's quite something. And the second opportunity?
The second opportunity is in what's described as the pre-collapse stage of the articulation, referencing FICAT stage 3.
So flattening or crescent sign, but not full collapse yet.
Exactly. Structural changes are present, but the joint hasn't fully caved in. Here, the goal of HBO2 is framed a bit differently. It's more about buying time before a patient must undergo total hip arthroplasty.
Right.
As the source notes, without intervention like HBO2 at this stage, progression to THA is often the usual clinical course of the disease, so HBO2 might delay that inevitability.
Okay, so to quickly recap Chapter 1. We've defined avascular necrosis, or aseptic osteonecrosis, as a condition caused by reduced blood supply leading to hypoxia and bone death, mainly in the femoral head, but also other terminal vascular beds. We highlighted its impact, subtle onset, progressive pain affecting active adults, significant socioeconomic cost, including those rising rates of total hip arthroplasty. We detailed the FICAT staging system based on radiography, stressing the crucial role of MRI as the current gold standard, describing each of the 4 stages from painful but radiographically normal, stage 1, all the way to full collapse, stage 4.
Yep.
We covered the treatment goal spectrum, aiming for joint preservation early, but acknowledging mandatory THA and FICAT stage 4. And importantly, we tied the staging directly to the specific opportunities for hyperbaric oxygen intervention, potential for full recovery in FICAT stage 1 and 2, and buying time in FICAT stage 3.
Excellent summary. So just to check your understanding from this foundational chapter for you listening as well, based on the source description, what are the key plain radiographic findings that differentiate FICAT stage 2 from FICAT stage 3? What's the big jump?
Good question. That's a critical distinction for treatment planning. Stage 2 shows changes within the bone, right, like increased density or cystic areas, but the femoral head maintains its overall spherical shape. Stage 3 is when you see the structural failure begin the flattening of the femoral head and that telltale subchondral fracture line, the crescent sign.
Perfect.
It's the difference between changes inside the bone versus changes to the bone's overall shape and integrity.
Couldn't have said it better myself. That distinction is absolutely key.
All right, let's move into Chapter 2. Now that we understand what avascular necrosis is and how we stage it, let's survey the landscape of existing treatments other than hyperbaric oxygen therapy as described in the source material. We'll start with medical treatments. What's out there?
Okay. The sources list a range of medical treatments that have been proposed and used for AVN. These include the standard stuff for pain management, like analgesics and anti-inflammatories.
Right.
but also agents aimed perhaps more at the potential underlying causes or the disease process itself, things like anticoagulants, vasodilators, statins, and also bisphosphonates.
And how are these typically used?
The sources note that these are often the usual first-line treatments employed when clinical symptoms like pain are present, particularly when they might predate visible radiographic changes on an X-ray. They help manage symptoms and can potentially assist in stratifying disease severity or maybe identifying underlying risk factors.
But it sounds like there are limitations to these medical approaches on their own. They don't cure it.
Absolutely not. The sources point out that pain relievers and anti-inflammatories, while necessary for symptom management, obviously cannot resolve all aspects of the condition as standalone therapies. The symptomatology often worsens despite these measures, making movement increasingly complex and painful, especially when a major weight-bearing joint like the hip is involved.
And there's a significant cautionary note regarding bisphosphonates specifically, isn't there? Something clinicians really need to be aware of.
Yes, this is critical. The sources discuss the risk associated with bisphosphonates when used for avascular necrosis treatment. They specifically detail the complication known as bisphosphonate-related osteonecrosis of the jaw, or BRNJ.
BRNJ. Yeah, I've heard of that.
It's a well-recognized and serious adverse effect. It's characterized by leading to exposed bone or an osteocutaneous fistula, basically a hole between the bone and the skin or mouth, lining in the maxillofacial region in the jaw. It's a significant risk that needs to be carefully weighed when considering this class of medication for AVN.
Definitely something to discuss with patients. So medical therapies play a role, especially early on for symptoms, but they have clear constraints and that potential major risk with bisphosphonates. What about non-operative procedures described in the source? Things you do to the patient but without cutting.
Right. The sources discuss extracorporeal shockwave therapy, or ESWT. This is a non-invasive treatment modality. It actually originated from the technology used in extracorporeal shockwave lithotripsy, ESWL.
Oh, the kidney stone treatment.
Exactly, the same basic idea, using focused sound waves.
And how does it work in the context of bone? How is it applied?
An applicator delivers mechanical energy, those shock waves, superficially through the skin at safe, recommended energy levels targeted at the affected bone area. The sources mention publications describing a positive effect of ESWT in the treatment of femoral head necrosis. They report benefits both in clinical terms, like pain reduction, and in relation to improvements seen using the Association Research Circulation Osseous, or RRCO, staging system for femoral head necrosis, which is another staging system, similar in purpose to FICAT.
So there's some evidence for its use, but maybe it's not a home run.
That seems to be the gist. The sources note that while there are positive reports, ESWT has not been shown to be as consistently successful in treating femoral head necrosis as it is proven to be in other applications. Specifically, the treatment of delayed fracture healing and pseudoarthrosis non-healing fractures, where ESWT has a much more established and stronger track record of success.
Okay, so promising, maybe, but not as proven as for some other bone problems. What other non-operative procedure is mentioned?
Pulsed electromagnetic fields, or PEMFs, are also discussed. These therapeutic fields are credited with several potential beneficial effects in the context of avascular necrosis.
Such as? What are they thought to do?
Well, PEMFs are thought to promote osteogenic activity in the necrotic area, essentially stimulating the formation of new bone.
Okay, bone building.
Right. They're also considered capable of enhancing bone repair processes, exerting a chondroprotective influence on articular cartilage, helping to protect that vital joint surface, as well as potentially preventing those tiny trabecular fractures and the dreaded subchondral bone collapse that characterizes the later stages of AVN.
Sounds like a lot of potential benefits. How are PMFs typically used in practice?
The sources state that PMFs are often used in conjunction with other therapeutic methods rather than as a sole treatment. Their goals kind of align with the broader treatment spectrum we discussed, either to obtain a reasonably stabilized injury, particularly when the disease is identified at its very initial stages,
Right.
or to buy time in more advanced settings when the eventual need for prosthetic replacement, like a total hip arthroplasty, seems impending, but clinicians are trying to delay it as long as possible.
Okay, so adjunct therapy or buying time. Let's move on to the operative approaches described. Cutting bone now.
The first surgical approach discussed is cord decompression, or CD. This involves creating a channel, or sometimes a series of channels, surgically drilled into the affected bone of the femoral head.
What's the thinking behind drilling holes in the bone?
The primary goal of this procedure is mechanical. It's to decrease the internal pressure within the bone.
Ah.
The source explains this comes with the potential for a simultaneous improvement of the compromised microcirculation in the area, simply by relieving that pressure. The source even draws an interesting analogy,
Oh, yeah.
comparing this local decompression effect to what happens in dentistry when a root canal treatment is performed as an initial prompt response to pulpitis occurrence. It's about relieving pressure within a confined space.
That makes sense. And what's the immediate benefit for the patient?
An immediate reduction in pain is a common and significant result of core decompression, according to the sources. Pain relief is often quite traumatic.
And its effectiveness, does it work long-term?
The source indicates that core decompression alone is often effective as a standalone treatment for early FICAT stage lesions, likely stage 1 and perhaps very early stage 2.
But it sounds like its effectiveness might be limited in more advanced cases. Is that right?
Yes, that's a key point. In more severe grades of the disease, likely later stage 2 or stage 3 core decompression alone often requires supplementation with further adjunctive therapy to have a more significant and lasting effect on the necrosis component of the lesion itself.
And what kind of adjuncts are we talking about?
Well, the source explicitly includes hyperbaric oxygen therapy as one of these necessary adjuncts when using core decompression for more severe grades.
Ah, there's that potential synergy again.
Exactly. They also mention other specific injections that have sometimes been added after the core decompression procedure to try and stimulate the healing of damaged tissue, things like platelet-rich plasma or PRP or bone marrow aspirate concentrate or BMAC derived from the patient's own body.
Okay. And finally, the definitive operative approach for the later stages, total hip arthroplasty.
Correct. Total hip arthroplasty, or THA, is described as indicated when collapse and concomitant arthritis secondary to the collapse of the necrotic femoral head are present, essentially FICAT stage 4, where the joint is significantly damaged.
And at that stage, THA is the best option.
At that advanced stage, total hip arthroplasty is presented as the most reliable and proven option for the treatment of avascular necrosis. It replaces the damaged femoral head and sometimes the scapular socket, providing a new functional joint surface.
What's the strategy then for younger patients who might face this? You mentioned they get it in their 40s or 50s. A hip replacement might not last forever.
That's a very important consideration. The sources note a specific strategic consideration for particularly young patients, those around the mean age of 40 to 50 for AVN, or even younger, say in their mid-30s.
Yeah.
Before collapse occurs and while the condition of the bone still permits, the use of non-operative methods or core decompression, often with adjuncts like HBO2 or injections, can be employed specifically to buy time.
Buy time before the inevitable replacement.
Exactly. The rationale is to minimize the number of possible total hip arthroplasty operations and subsequent revision surgeries that a younger patient might face over their potentially long lifetime. Each replacement has a finite lifespan.
Okay, that makes sense. So to quickly recap Chapter 2, we've reviewed the landscape of non-HBO2 treatment modalities. We started with medical treatments like analgesics, anti-inflammatories, and bisphosphonates, noting their role in initial symptom management, their limitations as standalone therapies, and that significant risk of B or J, bisphosphonate-related osteonecrosis of the jaw, associated with bisphosphonate use.
Right.
We discussed non-operative procedures, extracorporeal shockwave therapy, ESWT, mentioning its origin from kidney stone treatment, its mechanism delivering mechanical energy, and evidence showing some positive effect in AVNFH, but maybe less consistent success than for fractured healing. And pulsed electromagnetic fields, PEMFs, detailing their credited effects on bone formation repair and cartilage protection, and their use often as adjuncts or for buying time. Finally, we covered operative approaches. Core decompression, CD, explaining its mechanism, relieving pressure, and maybe improving circulation, its efficacy alone in early stages, but needing adjuncts like HBO2 in more severe grades, and other potential adjuncts like PRP or BMAC. And then total hip arthroplasty as the mandatory treatment for advanced collapse, FICAT stage 4, noting the strategy of using earlier interventions to buy time, especially in young patients, to delay the need for THA.
Excellent overview. Okay, before we dive into the specifics of hyperbaric oxygen itself, let's take a moment for a mega recap. Pulling together everything we've covered in chapters 1 and 2, give everyone a breather and consolidate.
Good idea. We started with the fundamental understanding of avascular necrosis, or aseptic osteonecrosis, framing it as a pathology driven by compromised blood supply leading to hypoxia and bone death. We focused on its most common and impactful site, the femoral head, but also acknowledged its potential to affect other terminal vascular beds throughout the body.
Right, and we reinforce the clinical impact. It's often subtle, late symptom onset, the progression of pain from weight-bearing to nocturnal pain, the significant burden it places on patients often in their most active years, and its socioeconomic cost, starkly highlighted by those increasing rates of total hip arthroplasty.
And we reiterated the FICAT staging system as the essential tool for classifying the severity of a vascular necrosis of the femoral head based on radiographic changes. We walked through those 4 stages again, moving from invisible disease on X-ray in stage 1 through increasing radiographic changes within the bone in stage 2, the critical structural flattening and the crescent sign in stage 3, up to full collapse and joint space narrowing in stage 4. And we stressed that while historically based on plain X-ray, MRI is now the undisputed gold standard for accurate diagnosis and assessment.
Perfect. We then summarized the goal-directed treatment approach, clearly aiming for joint preservation in earlier stages, but contrasting that with the necessity of total hip arthroplasty once advanced bone collapse, FICAT stage 4, is present. There's a definite switch point.
And in Chapter 2, we briefly listed the other treatment modalities explored, medical therapies for symptom management, while strongly cautioning about the significant risk of Bron-J with bisphosphonates. We mentioned non-operative options like ESWT and PEMFs, noting their varying evidence and roles as adjunctive therapies or perhaps for buying time. And we covered operative strategies, including core decompression, effective alone early on but needing adjuncts like HBO2 later, and total hip arthroplasty as the final, most reliable option for advanced collapse, highlighting its use in younger patients sometimes being delayed by these earlier interventions.
Great. This provides us with the necessary context of AV itself and its conventional treatments. Now, we are perfectly positioned to pivot and focus specifically on hyperbaric oxygen therapy, exploring its proposed mechanisms of action and the clinical evidence supporting its use. We've already seen it hinted at as potentially improving the core hypoxic condition and maybe being used as an adjunct to core decompression. Let's dive into HbO2 itself.
All right, let's get into the core of our deep dive. Hyperbaric oxygen therapy in a vascular necrosis. Chapter 3 focuses on how this therapy is thought to work and the rationale for using it. What's the basic appeal?
Well, the initial rationale presented in the sources is quite compelling, particularly when you compare it to the operative options we just discussed, like core decompression or THA. Hyperbaric oxygen may provide a beneficial effect without the invasiveness of surgery.
That's a big plus, obviously.
Huge. For patients and clinicians looking to avoid or delay surgery, this is a very attractive starting point. Less risk, less recovery time, potentially.
But the real interest lies in the proposed mechanisms of action. How does simply breathing high concentrations of oxygen under pressure actually influence a problem like bone necrosis? It seems almost too simple.
It does, but that's the fascinating part. The fundamental principle is that hyperbaric oxygen, by delivering 100% oxygen under increased atmospheric pressure higher than normal atmospheric pressure in a special chamber, significantly increases the extracellular oxygen concentration in tissues throughout the body, including bone. You're essentially supersaturating the body fluids with oxygen.
Okay, so more oxygen gets to the tissues. How does that translate into effects on the necrotic bone specifically?
This high concentration of dissolved oxygen, carried in the plasma, not just the red blood cells, has several important effects. One is reducing cellular ischemia, the oxygen deprivation, and reducing edema, or swelling, within the tissue.
And how does it reduce swelling? That seems key in a tight space like bone.
Right. The source explains that it achieves this partly by inducing vasoconstriction, a narrowing of blood vessels.
Now, hang on. That sounds counterintuitive again, doesn't it? We just said the problem is reduced blood supply. Why would you want to constrict blood vessels even more?
It absolutely seems paradoxical, doesn't it? But the key is the sheer amount of oxygen delivered. While vasoconstriction does slightly reduce the volume of blood flow, the amount of oxygen carried by the plasma, dissolved under that high pressure, is so dramatically increased that the net effect is significantly improved tissue oxygenation, even in areas with reduced flow.
Ah, okay. So the concentration effect outweighs the flow reduction.
Exactly. Furthermore, that vasoconstriction helps reduce compartmental pressure from edema within the rigid bone structure. This is critical in AVN, where increased intraosseous pressure is thought to be a major part of the problem, contributing to pain and further ischemia.
Right.
By reducing edema and pressure, you ultimately improve tissue oxygenation where it's needed most, despite the slightly reduced flow volume. You can think of it as essentially forcing a greater quantity of oxygen into those deprived tissues by dramatically increasing the dissolved oxygen content in the fluid portion of the blood.
Okay, that makes more sense. Beyond that general effect on ischemia and edema, The sources mention specific effects on the bone marrow itself, which seems highly relevant in a bone condition like AVN.
Yes, definitely. The sources detail that effects of hyperbaric oxygen include reducing bone marrow pressure. This aligns perfectly with the idea of reducing edema and compartmental pressure within the bone. Think of it like releasing tension within a rigid, confined space inside the bone.
Okay.
This reduced pressure, combined with the increased oxygen delivery to those ischemic bone cells, helps relieve the sort of compartment syndrome that can occur within the bone. This is thought to contribute to pain and progression, potentially preventing further necrosis.
And a direct clinical benefit is noted from this mechanism, right?
Crucially, yes. The source points out that the decrease in bone marrow pressure specifically leads to significant pain relief. This ties directly into the clinical presentation of AVN, where pain is often a major symptom, and is thought to be related, at least in part, to that increased interosseous pressure.
Another key mechanism mentioned is the stimulation of healing processes. Does HBO2 help rebuild things?
Yes, it does. Hyperbaric oxygen is well known from wound healing studies to stimulate angiogenesis, the formation of new blood vessels.
Ah, new blood supply.
Exactly. This is absolutely vital for potentially reperfusing the area affected by that initial reduced vascularization, bringing in the necessary blood supply, nutrients, and cells required for healing.
And the sources delve into its influence on bone remodeling itself. Can you explain that process in the context of AVN and how HBO2 might affect it? This seems quite complex.
It is, but it's essential to understanding bone health. Bone remodeling is a continuous process throughout life, maintaining bone integrity. It involves a really finely tuned balance between two main cell types: osteoblasts, which are responsible for depositing new bone tissue.
The builders.
The builders, exactly. And osteoclasts, which break down and resorb old bone.
The demolition crew.
Right. Their activity is regulated by a complex signaling system, notably involving molecules like osteoprotogerin, or OPG, the receptor activator of NF-kappa B ligand, or NNKL, and its receptor, rank. This remodeling process prevents the accumulation of old, brittle bone, adjusts bone architecture to stress, and repairs microscopic damage.
So what happens to this balance in a condition like a vascular necrosis? Does it get thrown off?
It certainly can. In pathological states like AVN, this delicate balance can shift dramatically. If the balance tilts too much towards bone resorption by osteoclasts, it can lead to pathological states like osteolysis, excessive bone breakdown, degradation, and ultimately collapse of the femoral head.
Okay.
The sources note that some studies correlate severe osteolysis and osteonecrosis with altered expression levels of OPG and RNKL, suggesting this signaling pathway is definitely involved in the disease process.
And this is where HBO2 comes in, according to the sources. It can influence this balance.
Exactly. The sources present findings from published research, specifically citing a study by Hadi et al., who showed that hyperbaric oxygen actually accelerates osteoblast differentiation, meaning it encourages those bone-building cells to mature and become more active.
Good.
And at the same time, it suppresses osteoclastgenesis activation, inhibiting the formation and activity of those bone-resorbing cells.
So boosting the builders and slowing down the demolition crew.
Precisely. This dual action effectively shifts the balance between bone formation and bone resorption in a direction that strongly promotes regeneration and repair, which is exactly what you want when treating necrotic bone.
The sources also mention that the exact mechanism by which HBO2 promotes bone formation is still being studied, but they highlight a specific finding from a recent publication regarding OPG and ORNKL.
Yes, they do. They note a recently published work showing that hyperbaric oxygen significantly increases serum OPG concentration. OPG acts like a decoy receptor, blocking RNKL from activating osteoclasts. But interestingly, this study found that HBO2 did not substantially affect serum RNKL levels.
So it boosts the inhibitor OPG, but doesn't change the activator RNKL much.
That's what this particular study suggested. Interpreting this finding, the sources suggest that a hyperbaric oxygen protocol involving, say, 30 treatments at 2.5 absolute atmospheres of pressure may reduce osteoclast activation primarily by increasing OPG levels at the onset of intraosseous ischemia. By increasing the ratio of OPG to RNKL, you effectively put a brake on bone resorption, further favoring bone formation and repair.
Fascinating. Beyond bone cells, HbO2 also seems to influence the general tissue environment by modulating things like oxidative stress and growth factors.
That's another important layer of the mechanism. High oxygen partial pressures delivered during HbO2 treatments can lead to an increased production of reactive oxygen species, or ROS, and reactive nitrogen species, or RNS, in various tissues.
Now, ROS are often thought of as bad, causing damage.
They can be in excess. But controlled studies, as referenced in the sources, show that the clinical efficacy of HbO2 seems to depend on a beneficial modulation of intracellular transduction cascades, signaling pathways within cells. This modulation actually drives the synthesis and release of beneficial growth factors that are essential for promoting wound healing and alleviating post-ischemic and post-inflammatory injuries. So it's a controlled signaling, not just random damage.
Is there specific evidence of this modulation in the context of a vascular necrosis of the femoral head, like measuring inflammatory markers?
Yes, the sources report results from a specific treatment protocol mentioned. They state that in AVNFH, hyperbaric treatment facilitates oxygenation and reduces edema by creating that high concentration of dissolved oxygen and inducing vasoconstriction. The report results where patients were treated with 2 cycles of HbO2, each consisting of 30 sessions with a 30-day break in between.
Okay.
Each session involved 90 minutes of 100% inspired oxygen at 2.5 chambers. Absolute atmospheres of pressure. The results showed a significant reduction in TNF-alpha and IL-6 plasma levels over time.
And those are?
TNF-alpha and IL-6 are key pro-inflammatory cytokines. So seeing their levels drop indicates a positive modulation of the inflammatory response and oxidative stress environment within the patient, further contributing to a more favorable healing milieu.
This whole discussion about mechanisms improving oxygen, reducing pressure, promoting good remodeling, calming inflammation, it seems to underline the importance of catching AVN early, doesn't it?
Absolutely. It hammers it home. The sources reiterate the critical importance of early diagnosis of osteonecrosis. They even highlight recent data advocating for screening MRI in asymptomatic patients, particularly those with conditions known to be associated with AVN.
Like which ones?
Like patients being treated for lymphoblastic leukemia, for example, where corticosteroid use is common and is a major known risk factor for AVN. Screening might pick it up before symptoms even start.
And the purpose of that early diagnosis is?
The purpose is precisely to enable the start of conservative treatment strategies before irreversible structural damage occurs. This is the window where modalities like hyperbaric oxygen can potentially play a significant role.
Yeah.
Intervening at a stage where its mechanisms of improving oxygenation, reducing pressure, and promoting favorable bone remodeling can actually have the greatest impact on the outcome.
Makes sense. And all of this understanding and the accumulating published evidence have led to some formal recognition for hyperbaric oxygen in AVN treatment, right?
Yes. The sources state that the published evidence demonstrating the beneficial effects of HbO2 on osteonecrosis led to its acceptance with a Class IIB evidence grade for the treatment of femoral head osteonecrosis by the 10th European Consensus Conference on Hyperbaric Medicine.
Class 2B, what does that generally mean in terms of recommendation strength?
Class IIB generally implies that usefulness or efficacy is less well established by evidence or opinion, or that the benefit might outweigh risk in some situations but not others. It suggests it's a reasonable option to consider, but maybe not as strongly recommended as a Class 1 or 2A indication.
Okay. And this was a European conference?
Yes, held in Lille, France, back in April 2016. The sources explicitly state that femoral head osteonecrosis was accepted as a condition treatable with HbO2 in Europe, based on this gathered evidence, placing it within a defined category of accepted indications for hyperbaric therapy.
Okay, let's do a micro recap of Chapter 3. We covered the rationale for using hyperbaric oxygen in avascular necrosis, highlighting its non-invasive appeal. We then delved into the detailed proposed mechanisms, how it increases oxygen delivery under pressure, reduces edema and bone marrow pressure via induced vasoconstriction, explaining that paradox, stimulates angiogenesis, new blood vessel growth, influences bone remodeling by accelerating osteoblast differentiation and suppressing osteoclast activation, mentioning the OPG rankle-rank dynamics and the specific finding of increased serum OPG, and modulates oxidative stress and inflammation, evidenced by the reduction in pro-inflammatory markers like TNF-alpha and IL-6 seen with the specific protocol. We touched on the link between these mechanisms and the importance of early diagnosis via MRI screening, and noted the formal acceptance of HbO2 for femoral head osteonecrosis with a Class IIB evidence grade by a European Consensus Conference.
Excellent. Just to make sure those mechanisms stick for you listening. Can you name at least 3 distinct ways hyperbaric oxygen is supposed to exert its therapeutic effects in avascular necrosis, according to the source material? Think about how it affects oxygen levels, pressure, and the bone cells themselves.
Okay, let's see. You'd be thinking about 1, increasing dissolved oxygen to combat the core problem of hypoxia. 2, reducing bone marrow pressure, which helps with pain and relieves that compartment syndrome effect. And 3, influencing bone remodeling specifically, promoting the osteoblast activity, the builders, and potentially suppressing the osteoclast activity, the demolition crew, maybe via that OPG pathway.
Fantastic.
Exactly.
Exactly. And those proposed mechanisms addressing the core problem of hypoxia, relieving pressure, and tilting the balance of bone remodeling towards repair provide a really strong biological rationale for its use in the right patients at the right time. Okay, let's integrate everything we've covered so far. This will be an end-of-chapter mega recap covering chapters 1, 2, and 3, pulling it all together.
Sounds good. We begin with the fundamental understanding of avascular necrosis, or aseptic osteonecrosis. We framed it as a debilitating condition driven by compromised blood flow leading to hypoxia and bone death. We emphasized its prevalence and significant impact, especially in the femoral head, but also noting its occurrence in other terminal vascular beds.
Right, and we recapped the critical importance of the FICAT staging system for classifying the severity of AVN of the femoral head based on radiographic changes. We walked through the progression from invisible disease in stage 1 to full structural collapse in stage 4, and highlighted MRI as the indispensable current gold standard for accurate diagnosis and assessment.
We briefly reviewed the spectrum of conventional medical, non-operative, and operative treatments available. We touched on medical therapies for symptom management, including analgesics and bisphosphonates, and the significant caution regarding J with bisphosphonate use. We mentioned non-operative options like ESWT and PMFs, noting their varying evidence and roles often as adjunctive therapies or for buying time. And we covered operative strategies, including core decompression, effective alone in early stages, but often requiring adjuncts like HBO2 later, and total hip arthroplasty as the necessary intervention for advanced collapse, particularly emphasizing the strategy of using earlier interventions to buy time, especially for younger patients.
Then, we dedicated significant time to hyperbaric oxygen therapy itself, delving into its proposed mechanisms in quite some detail. We reiterated how it works by increasing dissolved oxygen under pressure, reducing bone marrow pressure and edema via that induced vasoconstriction, stimulating angiogenesis, and influencing bone remodeling towards formation by accelerating osteoblast activity and suppressing osteoclast activation, referencing the OPG-NKL system and a specific finding of increased serum OPG. We also highlighted its role in modulating inflammation and oxidative stress, evidenced by reduced TNF-alpha and IL-6 in specific protocols.
We mentioned the crucial link between these mechanisms and the importance of early diagnosis, especially via screening MRI in at-risk populations, and how this enables the potential for successful conservative treatment with modalities like HBO2 before irreversible structural damage occurs. That timing seems critical.
Absolutely critical. And finally, we noted the formal acceptance of hyperbaric oxygen therapy for femoral head osteonecrosis with that Class IIB evidence grade by a key European consensus conference, demonstrating its recognized place within the treatment landscape based on published evidence.
Okay. This comprehensive understanding of AVN, its impact, staging, conventional treatments, and the detailed proposed mechanisms of HBO2 now perfectly sets the stage for us to look at the actual clinical evidence and reported outcomes that support these mechanisms and its formal acceptance. What does the data show? That's up next. Let's move into Chapter 4, which is really about the rubber hitting the road, the clinical evidence and reported outcomes for treating avascular necrosis, specifically with hyperbaric oxygen, as presented in the sources. First off, how do the sources suggest we measure how well a treatment is actually working in AVN? What are the outcome measures?
Okay. The sources highlight two primary ways to measure outcomes: imaging and clinical metrics. For imaging, magnetic resonance imaging, or MRI, is clearly stated as the gold standard.
Still MRI.
Still MRI. It's indispensable not just for early diagnosis, but also for identifying patients at risk of femoral head fracture before it happens, and for differentiating AVN from other diagnoses that might mimic its symptoms. The sources point out that specific findings on MRI, things like bone marrow edema and the proximal femur and joint effusion, are critical prognostic factors to look for. They tell you how active the process might be.
And how is MRI used to track progress after treatment?
A comparison between the initial patient assessment MRI and follow-up imaging taken at various intervals after completing a treatment series, typically 1 to 3 months later, is described as a reliable outcome check.
Okay.
It's considered a good measure of the improvement achieved at the tissue level because you can visually assess changes in the bone marrow signal, the edema, and the structural integrity over time.
Makes sense. Beyond the imaging, though, the sources emphasize that functional scores and pain scales are even better clinical metrics. Why is that?
Because these capture the patient's subjective experience, which is ultimately what we're trying to improve, right? Function and pain relief.
True. What specific scores are mentioned?
They specifically name the Harris Hip Score, or HHS, which is a very widely used patient-reported and objective score for hip function and pain, and also the VAS pain scale, the simple visual analog scale used for comparing pain levels before and after treatment. How much does it hurt on a scale of 0 to 10?
Okay, so imaging and clinical scores. Now let's get into the published evidence of HBO2 effectiveness presented in the sources. They start with a general reported success rate.
Yes, and it's quite a striking number they cite. The sources state that hyperbaric oxygen has been documented to have a success rate of 81% at the 7-year follow-up,
81%, that's high.
compared to only 17% for patients in the control group in that particular report.
All right.
That kind of difference is certainly attention-grabbing and speaks strongly to potential efficacy over a significant follow-up period.
Definitely. The sources also detail findings from a specific retrospective study by Visani and colleagues. What did that show?
Okay, this study looked back at patients with avascular necrosis of the femoral head enrolled between 2004 and 2013 who received hyperbaric oxygen treatment. They looked at outcomes at the 4-year follow-up after the patients completed their therapy.
And what were the results? Were they broken down by stage?
Yes. Crucially, the results were stratified by FICAT stage because, as we know, treatment success is highly dependent on the stage of the disease at presentation.
Right.
For patients presenting with FICAT stage 1 and FICAT stage 2 disease, the early stages, the outcomes were highly favorable. About 90% of these patients had no more need for surgery and remained pain-free at the 4-year mark.
90% avoided surgery and were pain-free. Wow. What about stage 3?
For patients with FICAT stage 3 disease, which is that pre-collapse stage, the success rate was understandably lower, but still significant. About half, or 50%, of these patients had no more need for surgery and remained pain-free at 4 years.
Okay, 50% is still pretty good for avoiding a hip replacement at that stage. Those are impressive, joint-preserving success rates, especially for the earlier stages. What conclusion did the Visani study support regarding hyperbaric oxygen?
As stated in the source, the conclusion drawn from the Visani study supports hyperbaric oxygen as a safe and effective therapy that can be administered and potentially combined with several physical treatments for patients with avascular necrosis of the femoral head.
Let's briefly compare the evidence for hyperbaric oxygen with that for core decompression again, which we discussed earlier as an operative option. How do they stack up in the sources?
Well, the source notes that historically, core decompression, or CD, was considered by many to be the most effective alternative to total hip arthroplasty for earlier stages, as described in an original article cited. It was kind of the standard joint-preserving surgery.
Okay.
However, a meta-analysis specifically looking at hyperbaric oxygen for AVN has also been shown to demonstrate its effectiveness, as we'll discuss more.
When looking specifically at the initial stages of AVN, the sources draw a direct comparison between HBO2 and CD, right?
Yes, they make a practical point. In the initial stages of AVN, hyperbaric oxygen often proves to be a more practical choice compared to core decompression. Why? Because it is significantly less invasive, it doesn't require surgery, and generally has a lower average cost associated with the treatment course compared to an operative procedure like CD.
Those are important factors for patients and healthcare systems. Less invasive, lower cost.
Absolutely. Important factors when considering treatment options, especially early on when you have a choice.
And interestingly, the sources mention again that these two approaches might not always be competing, but could potentially be synergistic, working together.
Exactly. Recent work, as referenced, demonstrates the synergistic activity of using hyperbaric oxygen after core decompression. This combined approach is being explored to improve the stage of the osteonecrosis lesion, particularly for more advanced lesions where core decompression alone might be insufficient to halt progression.
So maybe CD followed by HBO2?
That's the idea being investigated. It suggests a future where these therapies might be used in sequence or combination rather than strictly as mutually exclusive options depending on the stage and the patient.
Now, to get a more robust, pooled view of the evidence for HBO2 from multiple studies, the sources present findings from a meta-analysis assembled by Paderno et al. This is included as Table 1 in the source material, described as slightly modified. What did this big analysis show?
Right. This meta-analysis is powerful because it combines data from multiple controlled studies investigating hyperbaric oxygen therapy for avascular necrosis. Table 1, as you said, visually summarizes this data, likely using a forest plot which shows the results of individual studies alongside a pooled estimate of the overall effect across all included studies. This pooled estimate is really crucial for drawing more generalizable conclusions than any single study can provide.
What was the total number of patients included in this meta-analysis? Was it large?
It included a substantial number of patients, pooling data from multiple studies. A total of 368 cases in the hyperbaric oxygen therapy groups and 353 controls were included across the various studies analyzed. So, decent numbers.
And what statistical model was used to combine them?
The meta-analysis used a random effects model. This model is appropriate for pooling studies where you might expect some variability or heterogeneity between the studies, maybe due to clinical differences in patient populations, variations in HbO2 protocols, or methodological differences in how outcomes were measured. It provides a more conservative estimate of the pooled effect when that kind of heterogeneity is present.
Okay, and what was the key finding, the bottom line regarding clinical efficacy when pooling all this data?
The central finding is very compelling. The source states that the clinical efficacy in the hyperbaric oxygen group was a remarkable 3.84 times higher than in the control group.
3.84 times higher. That's a big effect size.
It really is. A powerful statement about the treatment's relative effectiveness compared to whatever the control groups received, which would typically be non-HbO2 standard treatments, or possibly placebo-sham therapy in some studies.
And was this difference statistically significant? Did it reach significance?
Yes, the source provides the specific statistical details, and the difference was highly statistically significant. The odds ratio, or OR, was 3.84, with a 95% confidence interval, or CI, ranging from 2.0 to 7.02.
Okay, and the confidence interval doesn't cross one, which is good.
Exactly. It doesn't cross one, meaning the result is statistically significant. And the p-value was less than 0.000001.
Wow, very low p-value.
Extremely low. That indicates that the observed difference in efficacy between the HbO2 group and the control group is extremely unlikely to have occurred simply by chance.
The table also includes information on heterogeneity. What did those statistics tell us? Was there much variation between the studies?
Yeah, the reported heterogeneity statistics were tau squared equal to 0.47, Che squared equal to 16.40 with 7 degrees of freedom, giving a p-value of 0.02, and importantly, I squared equal to 57%.
I squared of 57%. What does that mean practically?
An I-squared value of 57% indicates a moderate level of heterogeneity across the included studies. This means there was a fair amount of variability in the results from one study to the next. Maybe some studies showed a bigger effect than others.
Okay, but does that invalidate the overall finding?
Not necessarily. Importantly, the source emphasizes that despite this moderate heterogeneity, the test for overall effect with a z-score of 3.91 and that p-value of less than 0.0001 still confirms that when you pool all the data, there is a statistically significant overall benefit of hyperbaric oxygen.
So even with variations, the trend was strongly positive overall.
Exactly. While the magnitude of the effect might have varied somewhat between studies, the direction of the effect was consistently positive enough to show a strong overall benefit when combined.
The meta-analysis also looked at subgroups based on population, right? Asian versus non-Asian.
Yes. The meta-analysis included a subgroup analysis comparing Asian and non-Asian populations, as presented in the table. The source notes that the test for subgroup differences showed no statistically significant difference between these two broad groups. The stats were chi squared equals 0.37, 1 degree of freedom, p equals 0.55, and I squared equals 0%.
So the benefit wasn't just limited to one group.
Correct. This finding suggests that the beneficial effect observed in the meta-analysis wasn't limited to a specific geographic or ethnic population included in the analysis, at least based on this broad categorization.
So, reiterating the main conclusion from the Paderno meta-analysis.
The source clearly states that hyperbaric oxygen showed significant improvement in clinical efficacy compared to control groups. The numbers speak for themselves.
And comparing this meta-analysis finding again to core decompression evidence, how did the source position them?
The source makes a clarifying point, comparing this result to meta-analysis evidence that exists for core decompression as well, though only the HbO2 one is detailed here. It notes that despite a certain degree of heterogeneity within each meta-analysis, for both HbO2 and CD, both hyperbaric oxygen and core decompression demonstrated significant improvement in the respective primary outcomes of interest.
What were those outcomes?
For HBO2, the outcome mentioned was often pain-free status and avoiding surgery at a certain time point, like 4 years in the Visani study. For CD, it often related to preventing disease progression by ARCO or FICAT staging. Crucially, the source notes a high level of homogeneity across the studies taken into consideration regarding the primary finding for both, despite some potential within-study heterogeneity, meaning both showed consistent benefit across multiple studies.
Okay, let's do a micro recap of Chapter 4. We covered how outcomes are measured in AVN treatment, using MRI as the gold standard for imaging assessment pre- and post-treatment, to visualize tissue changes and prognostic factors like edema, and highlighting functional and pain scores like the Harris Hip Score and VAS as key clinical metrics capturing the patient's experience.
Yep.
We discussed the reported overall success rates for HBO2, that's striking 81% at 7 years compared to 17% control in one report, and detailed the Visani study findings, showing high percentages of patients avoiding surgery and remaining pain-free, particularly in FICAT stage 1 and 2, about 90%, and still a significant number in stage 3, about 50%.
Right. Stage matters.
We compared HBO2 with core decompression, noting HBO2's practicality and lower invasiveness costs in initial stages, and the potential for synergistic activity when used after core decompression for more advanced lesions. Finally, and most powerfully, we presented the compelling results from the Paderno-Ed analysis, demonstrating a robust 3.84 times higher clinical efficacy for the HBO2 group compared to control, backed by strong statistical significance. OR 3.84, 95%, CI 2.10, 7.02, P 0.0001. We discussed the moderate heterogeneity findings, concluding that despite this variability, the overall test for effect confirmed a significant benefit. We also touched on the lack of significant difference in subgroup analysis for Asian versus non-Asian populations.
Excellent summary. Okay, to test your recall of those specific numbers from the Visani study again, a quick question for you and everyone listening. According to the Visani study cited in the sources, what approximate percentage of patients with FICAT stage 3 of vascular necrosis treated with hyperbaric oxygen avoided the need for surgery and remained pain-free at the 4-year follow-up?
That was the lower but still significant group. About half, or 50%, achieved that outcome for stage 3. Much better than you might expect without treatment, but clearly less than the 90% seen in stages 1 and 2.
Precisely. Those numbers really highlight the stage-dependent nature of success, even with an effective therapy like HBO2 appears to be. Earlier is better. Okay, now let's build on our previous mega recap and integrate everything we've learned up through Chapter 4. This will be a substantial cumulative recap, pulling all the threads together.
Let's do it. Starting again from the foundation. Avascular necrosis, or aseptic osteonecrosis, is a debilitating condition driven by compromised blood flow leading to hypoxia and bone death. We've emphasized its prevalence and impact, especially in the femoral head, but also its occurrence in other terminal vascular beds, and its significant burden on active individuals and the healthcare system.
Right. We recap the critical importance of the FICAT staging system for classifying the severity of avascular necrosis of the femoral head based on radiographic changes, from invisible disease to full collapse, and how this staging fundamentally guides treatment decisions. We highlighted MRI as the indispensable current gold standard for accurate diagnosis and assessment, capable of identifying prognostic factors like bone marrow edema.
We reviewed the spectrum of conventional, medical, non-operative, and operative treatments available, noting their roles and limitations from initial symptom management with medications and the significant caution regarding Bron-J with bisphosphonates to non-operative therapies like ESWT and PEMFs used for potential positive effects or buying time. We covered operative strategies, including core decompression, effective alone in early stages but often requiring adjuncts like HBO2 later, and total hip arthroplasty as the necessary intervention for advanced collapse, noting the strategic use of earlier interventions to buy time, particularly for younger patients.
Then, we dove deep into hyperbaric oxygen therapy. We elaborated on its non-invasive appeal compared to surgery. We detailed its proposed mechanisms, how it combats hypoxia by increasing dissolved oxygen under pressure, reduces bone marrow pressure and edema via induced vasoconstriction, stimulates angiogenesis, and influences bone remodeling toward formation by accelerating osteoblast activity and suppressing osteoclast activation, referencing the OPG or ANKL system and the specific finding of increased serum OPG. We also highlighted its role in modulating inflammation and oxidative stress, evidenced by reduced pro-inflammatory markers like TNF-alpha and IL-6 in specific protocols.
And importantly, in this last chapter, we presented the compelling clinical evidence that underpins these proposed mechanisms and supports the use of HbO2. We discussed how outcomes are measured using MRI and clinical scores like the Harris Hip score and VAS. We summarized specific study findings like the Visani study, demonstrating high success rates in pain relief and avoiding surgery for early FICAT stages, remember, about 90% for stage 1 and 2, and about 50% for stage 3.
Crucially, we presented the powerful statistical evidence from the Paderno et al. Meta-analysis, pooling data from many studies and showing that significantly higher clinical efficacy for the HbO2 group, 3.84 times higher than control, with robust statistical backing. OR 3.84, 95%, CA 2.1, 7.802, P 0.00000. We acknowledge the moderate heterogeneity in the pooled studies, but emphasize that the overall test for effect still confirmed a statistically significant benefit. And we mentioned the lack of significant difference in the Asian versus non-Asian subgroup analysis and the Class IIB evidence grade acceptance in Europe.
Right. This substantial body of evidence, covering mechanisms and pooled clinical outcomes, really makes a strong case for considering HbO2 in the management of avascular necrosis, particularly in those earlier stages where joint preservation is still a realistic goal. Now, in our final chapter, we'll broaden the scope to look at AVN and other anatomical sites where HbO2 has been applied, and, most importantly, translate all this understanding into practical recommendations and specific treatment protocols outlined in the source, bringing it right back to direct clinical application for you listening. In this final chapter, Chapter 5, we'll finish our deep dive by looking at avascular necrosis in anatomical sites beyond the femoral head where hyperbaric oxygen therapy has been used, and then get into the really practical stuff. The recommendations and specific treatment protocols presented in the source material for implementing HbO2 in clinical practice, so AVN elsewhere in the body.
Yeah, while the femoral head is certainly the location that most frequently causes significant symptoms and is, frankly, the most extensively studied, the sources acknowledge that avascular necrosis can and does affect other areas as well. It's not just a hip problem.
Okay. They list several systemic conditions where AVN may occur in other sites and might be amenable to hyperbaric oxygen therapy.
They do. These include sickle cell anemia, which is a well-known risk factor for osteonecrosis throughout the skeleton. Also, saturation diver osteonecrosis, sometimes called dysbaric osteonecrosis, which is related to decompression stress experienced by professional divers.
Right, the bends can affect bone.
Exactly. Also, osteonecrosis potentially resulting from interferonopathy-mediated syndromes and osteonecrosis seen in children and adolescents, often related to extensive chemotherapy treatment, which frequently involves high-dose corticosteroids, a major known risk factor for AVN anywhere.
Beyond those systemic causes, the sources reiterate that theoretically any bone can be affected, but some are more common than others.
Right. Theoretically, all bones can develop osteonecrotic lesions. However, the segments most frequently affected are undoubtedly the terminal portions of the long bones, the epiphyses, the ends near joints. They again list specific frequently affected bony segments beyond the femoral head, including the femoral condyles in the knee, the humeral head in the shoulder, and bones in the foot like the talus, the calcaneus, and the navicularis. Basically, areas with somewhat tenuous blood supply.
So is there specific evidence presented in the sources for the effectiveness of HbO2 treatment in these other anatomical sites beyond the hip?
Yes, the sources provide some details from studies and clinical experience in other locations, though perhaps less robust than the hip data. They discuss a cohort study by Bosco and colleagues focusing specifically on femoral condylar necrosis in the knee that was treated with hyperbaric oxygen.
And what did they find in the knee?
They observed that after an initial 30 sessions of HbO2, 86% of patients experienced an improvement in their Oxford knee scores, or OKS, which is a validated outcome measure for knee function and pain.
86% improvement after 30 sessions sounds good.
It does, but interestingly, 11% actually worsened, and 3% did not change after those initial 30 sessions. However, importantly, the sources note that all patients in that study eventually improved in their Oxford knee scores after receiving a total of 50 sessions.
Ah, okay. So that's interesting, perhaps suggesting that more sessions might be needed in the knee compared to the hip for a full response. In some patients, maybe 30 isn't always enough there.
That's a reasonable interpretation of that finding, yes. What about avascular necrosis of the humeral head, the shoulder?
The sources present findings from personal communications from 2 clinicians with significant experience in this area. First, from a Xanon V in 2023, reporting experience with 12 patients over 8 years who had avascular necrosis of the proximal humerus, the top of the arm bone, And the results?
They observed good pain relief and functional results in 10 out of the 12 patients treated. The average age of these patients was 52 years, and they received a relatively high average of 63 treatments each.
63 treatments on average. It's quite a commitment for patients, isn't it? A lot of sessions.
It is. It suggests potentially longer treatment courses might be needed in some cases or locations, like the shoulder, compared to perhaps the hip protocols we'll discuss. The second personal communication is from a Dr. Christian Hayden, also in 2023, reporting extended outcomes on a larger cohort of 115 patients with AVN across a variety of anatomical regions, followed up to 12 years.
Okay, a bigger group. What was the overall finding?
Their overall finding was positive results in over 80% of patients treated with hyperbaric oxygen across these various sites. The average treatments per patient overall in this larger group was 22 treatments, administered at 2.4 absolute atmospheres of pressure for 90 minutes per session.
22 treatments average versus 63 in the other report. Interesting difference.
It is. Different cohorts may be different severities or protocols. Specifically for avascular necrosis of the humeral head within this larger group, most of the 9 patients treated responded favorably to HBO2.
The sources also provide a summary of recent results from several German hyperbaric chambers in their Table 2, which pools data across different sites. What does that add?
Right, Table 2 summarizes outcomes for a total of 115 patients treated across different anatomical locations in these German centers. It provides a breakdown by location. Knee with 72 patients, hip joint with 17 patients. These would be hip AVN cases, possibly distinct from the meta-analysis data, but adding to the overall evidence base. Tarsus calcaneus in the foot with 15 patients, and humerus in the shoulder with 11 patients.
Okay. And for each location, the table shows percentages for different outcomes, like improvement or needing surgery.
Yes, exactly. For each location, the table provides percentages for outcomes categorized as no residual symptoms, improvement, no change, and requiring operative procedure or OP necessary.
Can you give an example?
Sure. For the knee cases, 72 patients, 63.9% showed improvement, and only 5.5% went on to require an operative procedure. For the humerus cases, 11 patients, 18.2% showed improvement, and 9.1% required an operative procedure.
Okay, so the numbers vary a bit between sources and locations, which isn't surprising. The German humerus data looks maybe less impressive than the personal communications.
It does. It's worth noting the differing number of humerus patients and reported improvement percentages compared to the personal communications cited previously. The sources include both sets of data, likely from different sources and methodologies, which gives a fuller picture. Shows the range.
Okay. Building on all this evidence now from the hip, other sites, mechanisms the sources provide clear recommendations for the use of hyperbaric oxygen therapy in patients with avascular necrosis. What's the general take?
The overall recommendation is pretty straightforward. Hyperbaric oxygen should be included amongst the possible therapeutic options available for patients with AVN. It's presented as a valid tool in the clinical armamentarium. It deserves consideration.
However, they strongly emphasize that using HBO2 is not a decision to be made lightly or universally applied to everyone with ADN.
Absolutely not. They state it is mandatory to carefully evaluate any avascular necrosis patient before deciding to utilize hyperbaric oxygen therapy. Proper assessment is key.
And they list 2 helpful prerequisites that should ideally be met to ensure appropriate patient selection and management. What's the first one?
Prerequisite 1, patient selection based primarily on proper staging. The source states emphatically that proper staging of the patient is mandatory to allow for appropriate management strategies.
Okay, staging again. Which stages are best for HBO2?
They clearly recommend that hyperbaric oxygen therapeutic alternatives should be considered specifically in the initial stage of the disease. They define this initial stage based on imaging findings that report slight superficial edema of the spongy bone, corresponding roughly to FICAT stage 1 and early stage 2, where there isn't significant structural damage yet.
And why is that timing so critical?
Because, as the source explains, this aligns with the mechanism of improving hypoxia before significant structural collapse makes repair impossible. You're trying to intervene while the house is still standing, so to speak.
Right, and conversely, what about later stages?
Equally clear. They state that definitive surgical intervention for advanced AVN, defined as when there is collapsing cortical bone, essentially FICAT stage 4, should not be postponed in favor of trying HBO2.
Why not?
The reason given is that hyperbaric oxygen is not intended to fix collapsed bone structure. It can't rebuild a caved-in femoral head. And delaying necessary surgery at this advanced stage can be detrimental to the patient's outcome and may even complicate the eventual hip replacement surgery. So, Right stage, right patient.
Makes perfect sense. What's the second prerequisite mentioned?
Prerequisite 2, concomitant lifestyle changes. The sources state that these changes are needed to obtain a more prompt and stable recovery, and this is particularly crucial for patients with involvement of weight-bearing areas like the hip or knee, which are under constant stress.
What specific lifestyle changes are recommended?
The specific recommended lifestyle changes include avoiding jet overload during the treatment period. This usually means a significant reduction of weight bearing on the affected joint.
So using crutches or a walker.
Exactly. Crutches or other assistive devices are often necessary. Other critical recommendations are quitting smoking, which is known to impair circulation and bone healing significantly.
Huge factor.
Absolutely. And improving general physical status through careful weight management, as excess body weight increases the mechanical stress on weight-bearing joints, counteracting the potential benefits of the therapy.
So these lifestyle factors significantly impact the mechanical stress on the bone and the body's overall ability to heal effectively. And addressing them really supports the HBO2 therapy. It's not just about the oxygen.
Precisely. It's a package deal for the best chance of success.
Okay. Taking these recommendations, patient selection by stage, lifestyle changes, and the FICAT staging into account, the sources provide suggested treatment schemes for avascular necrosis of the femoral head. How are these laid out?
Yes. They outline 3 specific schemes that can be applied according to the different stages of the disease, explicitly using the FICAT classification as the guide. These are practical protocols.
Let's go through Scheme 1. Who is this for and what does it involve?
Scheme 1 is designed for FICAT Stage 1, the earliest stage, where pain is present, but no changes are visible on plain X-ray, though MRI would likely show edema. The stated goal for this stage is full healing.
And the protocol.
The suggested HBO2 protocol is 30 to 40 treatments. The frequency is 1 treatment per day, typically 5 days a week. The pressure recommended is 2.0 to 2.5 absolute atmospheres, or ATA, and the duration per session is 60 to 70 minutes at pressure.
Are there any variations mentioned for this scheme or a specific follow-up?
Yes, the sources add comments that several series describe longer exposure durations per session, sometimes up to 90 minutes, and they note that some protocols may add a short 10-minute air break during the session, particularly at higher pressures like 2.5 ATA, to reduce the risk of oxygen toxicity. Follow-up after completing this initial scheme is recommended with MRI and orthopedic evaluation at 1 month after completion of the treatment course to assess the outcome.
Okay, pretty straightforward for Stage 1. Now, Scheme 2 is for FICAT Stage 2. How does that differ?
Scheme 2 is for FICAT Stage 2, where radiographic changes are visible but the structural shape is still preserved. The goal here is termed lesional resolution, trying to resolve the necrotic lesion itself. The protocol is more intensive than Scheme 1, reflecting the slightly more advanced stage.
How so?
It starts with an initial phase of 30 to 40 treatments, administered once per day at 2.0 to 2.5. Absolute atmospheres for 60 to 70 minutes at pressure, just like Scheme 1.
But then there's a key difference.
Yes, this is the crucial difference.
Yeah.
Following that initial series, there is a mandatory pause of 20 to 30 days, a break from treatment.
Okay. Why the pause? Is that explained?
The source doesn't explicitly state the rationale for the pause, but often breaks were incorporated into longer hyperbaric protocols to allow tissues to adapt or consolidate changes and potentially minimize cumulative oxygen toxicity risk, though that's speculation. After this break,
Yes.
a second series is administered consisting of another 20 treatments, so it's a split protocol.
Got it. 30, 40, then a break, then 20 more, and the follow-up.
The follow-up recommended for Scheme 2 is similar. MRI and orthopedic evaluation at 1 month after the completion of this second series of treatments to assess the combined effect of the full protocol.
Okay. Finally, Scheme 3 is for later stages. FICAT Stage 3A or worse.
Scheme 3 is for FICAT Stage 3A or worse, representing late disease where structural compromise like flattening or the crescent sign is present, but there isn't yet full collapse. The goal for this stage is fundamentally different from the earlier stages.
How so? It's not aiming for cure anymore.
Correct. The goal is stated as a cost-benefit assessment of using HBO2 specifically in delaying the need for surgery.
So it's explicitly a palliative or time-buying approach, not considered curative at this stage.
Exactly. The source clearly frames this goal as needing to be weighed against the urgency and feasibility of prosthesis placement, the hip replacement. This is explicitly stated as a buying time or palliative approach, not curative at this advanced stage.
And the HBO2 protocol recommended for this stage for buying time.
It's to follow Scheme 2. 2, that same split protocol with the 30-40 initial treatments, the 20-30-day pause, and the subsequent 20 treatments.
Okay. And is this protocol repeatable if it seems to help a bit initially?
Yes, the sources state that this protocol in Scheme 3 is repeatable, perhaps once or twice, if the initial trial yields some benefit, but the disease is still progressing slowly or symptoms return after a while.
When would you repeat it?
The recommended timing to repeat it is at 4 to 6 months from the MRI and orthopedic assessment that followed the initial course.
And they give an example use case where this buying time approach might be particularly relevant.
Yes, they provide an example use case where this might be particularly beneficial. Pediatric patients with significant avascular necrosis of the femoral head related to extensive use of corticosteroids during chemotherapy for something like leukemia. For these very young patients facing potentially many surgeries over a lifetime, delaying the first total hip arthroplasty might be particularly desirable if HBO2 can achieve that safely.
That makes a lot of sense. The sources also mention a process for utilization review during treatment, a checkpoint.
Yes, utilization review is recommended after the completion of 40 treatments. This is presented as a key checkpoint, especially in the context of the longer or split protocols.
And how is that evaluation done?
The evaluation method for this review should include obtaining a new MRI.
After 40 treatments, when should that MRI be done? Right away?
No, the timing for this new MRI is important. It should be obtained at least a month later, presumably after the 40 treatments are completed.
And why wait a month?
The likely reason, as the source implies, is to allow sufficient time for any visible changes resulting from the treatment to develop and become apparent on the imaging. Assessing too soon after the last treatment might not show the full effect yet. You need time for the biological processes to manifest radiologically.
Got it. Okay, let's do a micro recap of this final chapter, Chapter 5. We discussed avascular necrosis in other sites beyond the femoral head, including those related to systemic causes like sickle cell anemia or chemotherapy, and other specific joints like the femoral condyles, knee, humeral head, shoulder, and bones in the foot. We looked at the evidence presented for these sites, including Bosco's data showing femoral condyle patients improved after 50 HBO2 sessions, and personal communications and German chamber data showing positive results for the humeral head and other locations, though with varying treatment numbers and success rates reported across different sources.
Right, less data than for the hip.
We covered the key recommendations for HBO2 use, mandatory careful evaluation of every patient, critical patient selection, emphasizing the initial stage based on imaging showing slight edema, FICAT early second, and importantly, not delaying necessary surgery for advanced disease with collapsing bone, FICAT stage 4. Alongside this, the necessity of concomitant lifestyle changes like reducing weight bearing, quitting smoking, and weight management to support outcomes.
Crucial points.
Finally, we detailed the 3 specific suggested HBO2 treatment schemes tied to FICAT staging for the femoral head. Scheme 1 for Stage 1, 30-40 treatments, 1 per day. Scheme 2 for Stage 2, 30-40 treatments plus pause plus 20 treatments. And Scheme 3 for Stage 3A or worse, repeatable Scheme 2 explicitly for buying time, outlining the number of treatments, pressure, time per session, and required follow-up evaluations including MRI and orthopedic assessment. We also covered the utilization review process after 40 treatments, including the timing for the follow-up MRI 1 month later.
Excellent summary of the practical application. Just to reinforce those protocols one last time, imagine you have a patient diagnosed with FICAT stage 2 of vascular necrosis of the femoral head. Based on the sources we just discussed, what specific HBO2 treatment scheme would be recommended, including that key break period?
Okay, FICAT stage 2. That would be Scheme 2. So an initial 30 to 40 treatments, once per day at 2.0 to 2.5 absolute atmospheres for 60 to 70 minutes. Then, that crucial pause of 20 to 30 days. And then following the pause, another 20 treatments. The follow-up MRI and orthopedic eval would be scheduled for 1 month after that second series is completed.
Perfect. That structured the split protocol for stage 2 is crucial for implementing the therapy as outlined in the source material.
Okay, now let's bring everything we've covered together one last time with a comprehensive final mega recap spanning all 5 chapters of this deep dive, really consolidating everything.
Seems good. We started by circling back to the initial definition of avascular necrosis as aseptic osteonecrosis, a debilitating condition driven by compromised blood flow and hypoxia leading to bone death. We emphasize its prevalence and impact, especially in the femoral head, but also its occurrence and challenges in other terminal vascular beds and its significant burden on patients and the healthcare system.
Right. We recapped the critical importance of the FICAT staging system for classifying severity based on radiographic changes, moving from invisible disease to full collapse, and how this staging fundamentally guides treatment decisions. We highlighted MRI as the indispensable current gold standard for accurate diagnosis and assessment, capable of identifying prognostic factors like bone marrow edema.
We reviewed the spectrum of conventional medical, non-operative, and operative treatments available, noting their roles and limitations from initial symptom management with medications and the significant caution regarding Bronje with bisphosphonates to non-operative therapies like ESWT and PEMFs used for potential positive effects or buying time. We covered operative strategies, including core decompression, effective alone in early stages but often requiring adjuncts like HBO2 later, and total hip arthroplasty as the necessary intervention for advanced collapse, emphasizing the strategic use of earlier interventions to buy time, particularly for younger patients facing potential future surgeries.
Then, we dedicated significant time to hyperbaric oxygen therapy, delving into its proposed mechanisms in detail. We reiterated how it works by increasing dissolved oxygen under pressure, reducing bone marrow pressure and edema via induced vasoconstriction, stimulating angiogenesis, and influencing bone remodeling towards formation by accelerating osteoblast activity and suppressing osteoclast activation, referencing the OPG-ANKL system and the specific finding of increased serum OPG. We also highlighted its role in modulating inflammation and oxidative stress, evidenced by reduced TNF-alpha and IL-6 in specific protocols.
We presented the compelling clinical evidence that underpins these proposed mechanisms and supports the use of HBO2. We discussed how outcomes are measured using MRI and clinical scores like the Harris Hip Score and VAS. We summarized specific study findings like the Visani study, demonstrating high success rates in pain relief and avoiding surgery for early FICAT stages, recalling about 90% for stage 1 and 2 and about 50% for stage 3.
Crucially, we presented the powerful statistical evidence from the Paderno et al. Meta-analysis, pooling data from many studies and showing that significantly higher clinical efficacy for the HBO2 group, 3.84 times higher than control, with robust statistical backing, OR 3.84, 95% CI 2.10, Peta 0.02, P 0.0001. We acknowledged the moderate heterogeneity in the pooled studies, but emphasized that the overall test for effect still confirmed a statistically significant benefit. And we highlighted the formal acceptance of HBO2 for femoral head osteonecrosis with that Class IIB evidence grade by a key European consensus conference.
We touched upon the evidence base emerging for other anatomical sites beyond the femoral head, including the femoral condyles and humeral head, presenting findings from specific studies and collections of data from hyperbaric chambers, showing potential benefit in these areas as well, although perhaps with varying outcomes and treatment numbers reported, suggesting more research might be needed there. And we reviewed the practical recommendations for implementing HBO2. Emphasizing the mandatory careful patient evaluation, the critical role of proper staging for patient selection. HBO2 is best considered for the initial stage with slight edema on imaging, FICAT early 2, and importantly, necessary surgery for advanced disease with collapsing bone, FICAT stage 4 must not be delayed, alongside necessary concomitant lifestyle modifications like reducing weight bearing, quitting smoking, and careful weight management to support better outcomes.
Finally, we detailed the specific, stage-based HBO2 treatment protocols presented in the sources for avascular necrosis of the femoral head Scheme 1 for FICAT Stage 1, Scheme 2 for FICAT Stage 2, and Scheme 3 for FICAT Stage 3A, or worse, outlining the recommended number of treatments, pressure, time per session, and the required follow-up evaluations, including MRI and orthopedic assessment. We also covered the utilization review process recommended after 40 treatments, specifying the timing for the necessary follow-up MRI 1 month later.
Wow. This deep dive has truly taken us through the complex landscape of avascular necrosis treatment. We've systematically explored the condition itself, the conventional treatment options, the detailed proposed mechanisms by which hyperbaric oxygen therapy is thought to work, and perhaps most importantly, the clinical evidence supporting its use, particularly in the earlier stages of the disease, as strongly supported by the data we've examined from the source material, including that really compelling meta-analysis.
Yeah, absolutely. We hope this detailed exploration equips you in your own clinical practice to better evaluate patients presenting with possible AVN, to deeply understand the potential benefits and appropriate application of hyperbaric oxygen therapy based on staging and the available evidence, to confidently counsel patients on realistic expectations and the critical importance of those lifestyle changes, and perhaps to collaborate effectively with hyperbaric specialists if considering this modality as part of your patient's management plan.
As we've seen throughout this discussion, when applied according to the recommended protocols and patient selection criteria discussed, hyperbaric oxygen therapy really stands out as a less invasive option that can offer significant potential for joint preservation, or at least valuable time buying in specific scenarios, grounded in both plausible biological mechanisms and accumulating clinical evidence.
Which leads to a final thought, perhaps. Given the positive outcomes reported in the meta-analysis and specific studies for early-stage disease outcomes that could potentially alter the entire course of this often disabling condition for many patients, how might we, as a community of clinicians and researchers, work more effectively to ensure earlier identification of avascular necrosis, perhaps through more targeted screening in at-risk populations? And how can we improve access to non-invasive or joint-preserving therapies like hyperbaric oxygen for the appropriate patients who stand to benefit the most, potentially changing the trajectory away from inevitable joint replacement for some?
A really important question to ponder, something for all of us involved in treating these patients to think about moving forward.